Welcome to this episode of Conceptual Anesthesia. And today we'll be talking about sodium disorders. And since it's a vast topic, I have divided into hyponatremia, which will be covered today, and hypernatremia, which will be covered in the later class. So, first of all, I would like to give an introduction about sodium and the fluid balance. Because sodium disorder is not only a sodium disorder, this is mostly a volume disorder. So, we have to know about the extracellular volume and then think about whether sodium is high or low in a real life situation. So we'll be talking about hyponatremia today. So hyponatremia is the commonest electrolyte abnormality, and remember it is associated with increased morbidity and mortality. And this is because of its neurological symptoms. And especially when you think about correcting hyponatremia or assessing hyponatremia, it is very essential to know about the volume status and the urinary sodium levels and osmolalities because they are the key steps in appropriate diagnosis and treatment of hyponatremia. Symptomatic hyponatremia is a medical emergency and needs to be treated, as I said, because of neurological sequelae. So, we'll be talking about what is symptomatic hyponatremia. And remember, correction of hyponatremia, we've somehow ended many patients into a rapid overcorrection with the risk of osmotic demyelination syndrome. So, we'll be talking about that also in a bit of detail. So, total body water is a percentage of lean body weight. So in men and female, they take it as 0.6 and 0.5, and the body water is divided into intercellular fluid and extracellular fluid. We should know the major anions and cations. So in extracellular fluid, the major cations is sodium and major anion is chloride and bicarbonate. Intercellularly, major anion is potassium, major cation is potassium, and major anion is phosphate. So we should know sodium is usually present in extracellular fluid, and potassium is an intracellular cation. So we should be familiar with this concept. Then what is plasma osmolality? Plasma osmolality is determined by the ratio of plasma solutes and plasma water. And most of the plasma solutes are sodium salts with lesser contribution from other ions like potassium, calcium, glucose, and urea. And normally it ranges from 275 to 290 or 295 milliosmoles per kg. And the formula, as we all know, is plasma osmolality is equal to 2 into sodium, and sometimes we take as sodium plus potassium plus glucose divided by 18 and blood urine nitrogen divided by 2.8. So that is the formula, and the normal value is 275 to 290. Then what is plasma tonicity? So it is a parameter sensed by osmoreceptors and determines the transcellular distribution of water. So water movement is from a place from higher water content, that means low tonicity, to a higher tonicity, that is lower water content. So like all solutes also, water moves from a higher water content area to a lower water content area. And here urea is an ineffective osmole and is not used in the calculation of plasma tonicity or effective osmolality. Now we should think about how is the regulation of sodium and water balance. So changes in plasma osmolality are sensed by osmoreceptors in the hypothalamus, and these osmoreceptors are extremely sensitive, even to the tune of 1%. So influences the ADH release. What happens is when there is decrease in the blood volume or increase in the blood osmolality, so decreased blood volume leads to decreased blood pressure and increases angiotensin system. So this is the RAS activating system, renin angiotensin aldosterone act system. Another thing is that dry mouth and osmoreceptors in the hypothalamus, which are very sensitive to the tune of 1%, they stimulate the thirst center in the hypothalamus. When you stimulate the thirst center, there is increased thirst. Water is taken in and decreased blood osmolality eventually happens. So this is a normal phenomenon that happens in all of us. A word about ADH, what happens is, so when high blood osmotic pressure stimulates hypothalamic osmoreceptors, they activate the neurosecretory cells that synthesize and release ADH. And ADH from the axon terminals in the posterior pituitary is sent to the bloodstream, which acts in the kidney to retain more water. So it is anti-diuretic. Diuretic means releasing more water. It is anti-diuretic, so more retention of water happens and decrease in the urine output is there. It also acts as sudorifics, that is sweat glands, decreases water loss due to perspiration from the skin. and also leads to arterial constriction, leading to increase in blood pressure. So concept of effective arterial blood volume is there, and this is the adequate blood volume which fills the capacity of arterial vasculature in maintaining a normal cardiac status and venous return. And there is some changes in this in cirrhosis and congestive heart failure, where what happens is EABV, that is effective arterial blood volume, increases. So changes in body sodium content leads to change in extracellular volume and effective arterial blood volume, and is sensed by three major pressure receptors. So juxtaglomerular cells that sense the perfusion pressure in the kidney, they are a very important determinant of the activity of the, as I said, RAS, renin angiotensin aldosterone system. And then receptors in the carotid sinus and aorta regulate the activity of sympathetic nervous system. So increased sympathetic activity also increase the renin release. Then the third is the cardiac receptors regulate the release of atrial natriuretic peptide, that is from the atria, and brain natriuretic peptide, which is mostly from the ventricles. So these are how you regulate the effective arterial blood volume. These are the systems that act in conjunction to each other. This is the renin angiotensin aldosterone pathway in a bit of detail. So what happens when you have dehydration or hemorrhage or sodium deficiency? There is decrease in the blood volume and blood pressure. So as I told you, this is sensed by the juxtaglomerular apparatus in the kidneys. Increase in renin, which leads to increased angiotensin 1, and it is converted in the lungs by ACE, that is angiotensin converting enzymes, into angiotensin 2, which leads to the following effects. So angiotensin 2 is the effective one, which leads to vasoconstriction of arterioles, acts at adrenal cortex to increase aldosterone, which leads to increased sodium and water resorption and increased blood volume. And all of this vasoconstriction and increase in the blood volume leads to normalization of the blood pressure. So the aim of renin angiotensin aldosterone pathway is, when in hypovolemic states, you have to maintain the blood pressure. Now, what is hyponatremia? So some terminologies about hyponatremia. Serum sodium is less than 135 millicoins per liter. So normal is between 135 to 145, or 145 is taken as usually the upper limit. So less than 135 is hyponatremia. A very important distinction is between acute and chronic. So acute is which is developed less than 48 hours, and chronic is which is present for more than 48 hours. So an example of chronic hyponatremia is that you have a person that who's in the home, an elderly person who's having fever, who's taking less and less intakes. So an example of chronic hyponatremia, I told you, some elderly gentleman who's not able to take his own feeds. Can you all mute yourself? Yeah, Dr. Bharti, thanks a lot. So as I told you, a very important distinction is between acute and chronic hyponatremia. So there are different causes, but in chronic, as an example, we have patients who are febrile, who are on rice tube feeding, who are not able to take their own feeds, they are at home, and they develop slowly and slowly hyponatremia, maybe because of some diuretic that is being given, and that develops over the more than 48 hours, over some days. And acute is which develops suddenly less than 48 hours. So once you have, for knowing the etiology, you have measure the serum osmolality, assess the volume status, measure the spot urine sodium and urine osmolality. So one distinguish first is you have to diagnose hyponatremia. Second, you have to keep in mind whether it's acute or chronic. Third is you want to find the diagnosis. And before all of this, you have to know whether the true hyponatremia is there or not. So I'll be talking about all of them. So hyponatremia is either low serum, it can be with low serum osmolality, normal serum osmolality, or a high serum osmolality. So when hyponatremia is there, we expect that the serum osmolality is low. So when in hyponatremia there is low serum osmolality, that means it is true hyponatremia. When it is normal serum osmolality, can you all please mute yourself? So when it is normal serum osmolality, that means the sodium content on the body is low, but there is something or the other that is also contributing to osmolality. So that is why the measure osmolality is normal. And usually it is a very high level of hyperlipidemia or hyperproteinemia. An example of hyperproteinemia is Waldenstrom's macroglobulinemia or multiple myeloma. Another thing is high serum osmolality. Sometimes the serum osmolality is high. So although the sodium levels are low, but the osmolality is high. So then we suspect a very high degree of hyperglycemia or mannitol, or in TERP, when you do a transurethral dissection of prostate, you give high dose of glycine. So they may all cause high serum osmolality. So although sodium levels are low, the osmolality is high. So we should rule these causes of normal serum osmolality and high serum osmolality, and then diagnose the patient of hyponatremia with a true hyponatremia with low serum osmolality.